Okay, guys, so welcome back. We've got another protocol quiz to review, so let me take you through it. So the first question says, which one of the following drugs has the shortest duration of action? Now, this might seem like a pretty difficult question right off the bat, but remember that there's a couple drugs that we know are sort of on the far ends of the duration of action spectrum, right? On one hand, we have amiodarone, which has a duration of action of, or a half-life, I should say, of like 2 months. On the other hand, we have adenosine, which, as we know, or should know, has a half-life in the 10-second range. So if we're being asked about the shortest duration of action and adenosine is the answer, or adenosine is one of the answers, then that's going to be the correct answer, right? If you're going to know one thing about adenosine, what you have to know is that it has a very short duration of action, right? You give it, you have to push it very quickly, you have to follow by a saline flush so that it hits the heart quickly while it is still has some potency, and that, it turns out, is the correct answer here. Adenosine has the shortest duration of action. Okay. So question number 2 asks, which drug would be most likely to induce positive chronotropy in a patient in third-degree heart block? So remember, positive chronotropy means we're going to increase the heart rate, right? So the drugs that we generally use to increase the heart rate, we have epinephrine, we have dopamine, we have atropine. You have to remember that atropine is a parasympatholytic. It interrupts vagus nerve tone, and the vagus nerve really innervates the atria, but not the ventricles. In third-degree heart block, the ventricles are pacing themselves. So when we talk about a third-degree heart block, we need a drug that acts directly on the ventricles, and atropine is not that drug. Atropine, we generally would not expect, in most cases, to have any kind of positive chronotropy for a patient in third-degree heart block because there's complete blockade at the level of the AV node. Can you still give it? Yes, you can. There's evidence that it will increase preload by increasing the atrial rate, and in some cases, there are patients out there where the vagus nerve does innervate the top part of the ventricles, and so in some uncommon cases, you may even get positive chronotropy from your atropine, but it is not what we would expect. What we would expect, or rather what we would use if we had to pace this patient chemically, is epinephrine. Epinephrine acts directly on the ventricles. And if you want to see more on that and more on sort of where these different drugs act, please check out my Down on the Farm video talking about the pharmacology of cardiac drugs. It's goes into a lot of detail on all these things. Diltiazem, by the way, negative chronotropy. Adenosine, negative chronotropy briefly, right? Obviously it has a short duration of action, but negative chronotropy as well. So only 2 of these answers would even theoretically have positive chronotropy, but of those, you would not expect atropine to be very effective in third-degree heart block because of the complete blockade of the AV node. Okay. Question number 3. Which of the following drugs has an effect on the diameter or lumen of the blood vessels? We went through a couple revisions of this question, and I want to share with you the wording we had initially. The initial wording we had here was, which of the following drugs is vasoactive? And we decided that we would get rid of the word vasoactive because it might be confusing, but I want you to have the benefit of hearing it now. So vasoactive means something that has an effect on the diameter or the lumen of blood vessels, right? The internal area of those blood vessels. So let's start with the easy ones. Epi and norepi are both alpha agonists, right? And we have alpha-1 receptors in the vasculature, and so that causes vasoconstriction when they're activated. So norepi and epi both are clearly vasoactive. Now, the tricky one here is the diltiazem, because we think of diltiazem as being a calcium channel blocker, and so slowing conduction through the AV node, which is what it does, and that's why we give it. But what you have to remember is that there are also calcium channels in the blood vessels, and so when you give DILT, there is an effect on the lumen of blood vessels. You're knocking out a little bit of the blood vessel's ability to vasoconstrict, which is why, by the way, there is a caution on giving DILT to patients who are sort of borderline hypotensive. And so, therefore, all three of these drugs are vasoactive. And so the correct answer is D, all of the above. Now, from a test-taking strategy standpoint, even if you, I think the hardest piece of knowledge to get here is to know that DILT, which we think of as being something with an effect on the AV node, also has sort of this collateral effect on the blood vessels. So if you didn't happen to know that, from a test-taking strategy, you should know for sure. If you're going to know one thing about norepi, one thing about epi, they're alpha agonists, both of them. So if these two are both vasoactive, then the correct answer has to be all of the above, right? So just from a test-taking strategy, you sort of could have, by process of elimination, figured out the correct answer there. Okay, for question number 4, your only point of vascular access is a tibial IO. All right, that can happen. Your patient's in SVT. Okay, which would be the least likely to be effective at terminating the dysrhythmia? Well, this is a critical thinking question here, and what you have to remember is, again, this is sort of the same piece of knowledge that we were testing up here about durations of action. And adenosine has a super short duration of action, and when you give a drug like adenosine through a tibial IO, you have two things working against you. First, it's an IO. So IOs have a measure of resistance to them. Unlike IVs, where you can pretty much push things in very quickly, with an IO, there's going to be some resistance because you have to push it through all of the sort of narrow blood vessels in the bone, right? In the bone marrow, you have to push it through the bone marrow, and that's kind of like a filter on the end of the IO needle, and it takes some pressure to get it through there. As well, it's not just any IO, it's a tibial IO. So what does that mean? A tibial IO means the drug is going to be entering the body and starting to be metabolized as soon as it hits the bloodstream in the leg, and then it has to travel all the way back up to the heart. So when we talk about using adenosine to convert SVT, what we really want is a point of access that's as close as possible to the heart. So a tibial IO or any sort of lower extremity access is not that. And so for that reason, adenosine is not likely to be effective, because by the time it gets to the heart, after having been pushed through a tibial IO, it's very likely to have been just completely metabolized out due to the travel time and due to the fact that it's an IO. Okay, so just to flush out the rest of these answers, right? Could DILT work to terminate a dysrhythmia? Sure, it's a calcium channel blocker, slow conduction through the AV node, absolutely. Could metoprolol work? Yeah, metoprolol is a beta blocker, and so metoprolol would slow the atrial rate. And so if this is an ectopic atrial focus, metoprolol could absolutely convert this rhythm. And again, unlike adenosine, metoprolol doesn't have to be sort of slammed in very quickly. Finally, amiodarone, it's a sodium channel blocker, calcium channel blocker, potassium channel blocker, and a beta blocker. So amiodarone also is a valid choice for SVT. But here, if you have to use a tibial IO, adenosine is just not going to work. Okay, let's look at question number 5. Which of the below is a parasympatholytic? So parasympatholytic drugs are drugs that block parasympathetic nervous system tone. So atropine does that, and ipratropium does that. By the way, it's sort of in the name. There's a reason that atrope is in the middle of ipratropium. Also, atrovent, right? Ipratropium is very closely related to atropine. They're both parasympatholytics. So they're going to dry secretions. Adenosine, not a parasympatholytic, does not affect the parasympathetic nervous system. Epinephrine is a sympathomimetic, not a parasympatholytic. So of these, ipratropium is the correct answer. All right, which of these drugs, number 6, has the smallest chronotropic effect? So you've got dopamine, atropine, epinephrine, and norepi. So we're talking now not specifically about a situation where we have a third-degree heart block up here, but just in general, which has the smallest chronotropic effect. So let's talk about what each of these drugs does. Dopamine is a drug that's highly dose dependent in terms of what its effects are, but at lower doses, it does have strong chronotropic effects. So from 2 to 10 micrograms per kilogram per minute, the chronotropic effects are supposedly predominate over the vasoactive effects of dopamine. And so dopamine definitely is a drug with chronotropic effects. Atropine, parasympatholytic, as we just said, but for most patients, atropine also does have a chronotropic effect, right? That's why we give it. It's sort of our front line for bradycardia. And the idea is to increase the heart rate by blocking vagus nerve tone. So yeah, atropine as well does have a strong chronotropic effect, except in that one case we saw above, where the patient's in third-degree heart block. But unless that specific case is brought up and they're just asking about the general case, atropine does have chronotropy. Okay, so then epi. Well, we saw epi earlier as a potential positive chronotrope in patients with third-degree heart block. And yeah, epi does have positive chronotropy across all levels of the heart. So it's going to increase the firing rate of the atria, increase conductivity through the AV node, and increase the firing rate of the ventricles. So epinephrine as well absolutely does have a fairly strong chronotropic effect. Now, norepi. If you're going to know one thing about norepi, what I want you to know is that it is a primarily alpha agonist. And where are the alpha receptors? They're in the blood vessels, but they're not on the heart itself. So norepi is the drug of choice when you want to vasoconstrict without having as much of an effect on the heart rate. And there's a reason that we're asking you these questions, right? There's a reason that REMAC would ask you these questions. If you're going to push a drug, if you're going to decide whether to give a patient epi or norepi, you should have a basis for making that decision, right? We don't just pick a drug at random and throw it in and hope it works. You have an obligation to understand what these drugs are doing in the body. And so, again, I think the mental model you should have for epi is that it's a chronotrope, an inotrope, and a dromotrope, as well as a vasopressor. And for norepi, while it does have some minimal chronotropy, dromotropy, inotropy, the primary effects are vasopressor effects. And so for that reason, norepi is sort of our drug of choice for patients that are in like sinus tach, but are still in shock. So patients in, say, sepsis, sort of norepi is our treatment of choice because this is not going to overtax the heart, but at the same time it is going to vasoconstrict. Okay. So number 7 says, which of the below is contraindicated in patients with WPW? So remember that WPW is characterized by the existence of an accessory pathway that allows electrical impulses to bypass the AV node. And that accessory pathway is ungated, which means that the electrical impulses can be transmitted down there very quickly, and in fact, too quickly. So you can have a lethal arrhythmia if you end up pushing too many drugs, if you end up forcing electricity down this ungated sort of back channel. And so when does this become a problem? Well, it becomes a problem if we block off the front door, which is through the AV node. So if we induce calcium channel blockade, we force electricity through this ungated back channel, and then we get, again, this sort of uncontrolled flow of electrical impulses down the Purkinje system, depolarizing the ventricles at a rate that's too fast to be sustainable, and it can cause a lethal arrhythmia. So which type of drugs would cause that? Well, anything that induces blockade of the AV node, and the AV node is controlled by calcium channels, so what we're looking at is a calcium channel blocker. And by the way, this is actually a really good example of a multiple choice test taking strategy. And the strategy is to read the question and then predict what you think the correct answer would be, and then see if your prediction matches. So before we even look at these answers, based on the discussion we just had, we would expect that a drug contraindicated in WPW would be one that causes calcium channel blockade. So we're looking for a calcium channel blocker. So before we even look at the answers, we have a prediction. what we're looking for is a calcium channel blocker. So let's see if any of these are calcium channel blockers. Epi is not. Norepi is not. Lidocaine is a sodium channel blocker, not a calcium channel blocker. But, diltiazem is a calcium channel blocker, and it turns out that is the correct answer. All right, when we talk about polymorphic v-tac, number 8, which would be most appropriate to treat polymorphic v-tac? Well, generally, a common form of polymorphic v-tac would be torsades, right? Torsades. It's not the only form of polymorphic v-tac, but it is a common form, and the mental model that you need to have for these drugs is that polymorphic v-tac is most often caused by a critically prolonged QT interval. And so you're looking for a drug that shortens the QT interval. And answer D should have been changed, but as it's written, it actually gives you sort of a clue as to what we were looking for here. We're looking for a drug that shortens the QT interval, and we're looking to avoid drugs that prolong it. So Zofran lengthens the QT. Amio lengthens the QT. Mag sulfate, in contrast, shortens the QT. And so, therefore, mag sulfate is the most appropriate drug to treat polymorphic v-tac. Amiodarone should not be given for polymorphic v-tac. It shouldn't be given. It's dangerous. You are, in a sense, pushing the patient further in to that arrhythmia if you give amio. Okay. Here, this was, number 9 was a difficult question for a lot of people. Your patient's in a VFib arrest, secondary suspected opiate OD. Which of the following drugs are appropriate on standing orders? So critical point there, on standing orders. So, of course, the first drug that any patient in arrest gets is epi. Okay, so, again, patients in VFib arrest, secondary suspected opiate overdose. Any patient in arrest, the first drug they get is epi. Now, it's a VFib arrest, so amiodarone is also appropriate. Again, on standing orders, the first drug that any patient gets is epi. The drug for patients that are in refractory VFib, so we've attempted defibrillation at least twice. We give a sodium channel blocker, so that's be either amiodarone or lidocaine. So amiodarone certainly is appropriate on standing orders. Now, atropine, never appropriate for patients in arrest. We don't give it, so you can immediately cross that out. So that leaves naloxone. And this was the sort of contentious answer here. But it's important you understand why we don't give it. So, there's 2 reasons why naloxone is not correct here. So the first one, and the clearest one, is that it's not in the protocol, right? So if it's not in the protocol, you can't give it. Whether you think it's indicated or not, if it's not in the protocol, you can't give it. Now, you might try to argue that patient in cardiac arrest has an altered mental status, and we do have an altered mental status protocol that allows us to give Narcan. And it's true that the patients in cardiac arrest have an altered mental status. That's incontestably true. But you are not allowed to combine protocols that way. And you might say, well, how do you know that we're not allowed to combine protocols that way? And the way I know it is the way I know this is the cardiac arrest protocol. So let me show you this protocol. Okay. Okay. So if you look at the arrest protocol here, it says for number 15, obtain blood glucose level and treat as needed. Now, if we were allowed to combine protocols, that line would be unnecessary, wouldn't it? Because we would already be obtaining a blood glucose level and treating as needed under the AMS protocol. But it was included, which means clearly they don't expect us to combine these protocols. So the fact that that was included proves that you can't combine these protocols, and therefore we are limited to the options that are listed in this protocol. So Narcan is not among those options. Now, so that's the first reason why you can't give Narcan. So let's go back to the question here. Now, the second reason why you can't give Narcan is because it's not indicated, guys. Narcan is not indicated for patients in cardiac arrest. There is an AHA lay rescuer algorithm that says to give it, but the reason it says to give it is because they don't trust lay rescuers to tell the difference between cardiac arrest and respiratory arrest, basically. So, but as medical professionals, you're not lay rescuers, and your protocol doesn't say to give it. The reason it's not indicated is because there's evidence of harm, and there's not evidence that it helps. Remember, when patients go into cardiac arrest due to an opiate overdose, it's a hypoxic arrest. They've not been poisoned by the opiates. There's nothing about the opiates that's keeping them in arrest. It's the fact that they didn't breathe and they became hypoxic. That's what killed them. So you have to fix the hypoxia. Contrast that with a cyanide poisoning, right? Cyanide poisoning, you have to get rid of the poison to get a pulse back. Right? That's why we give hydroxycobalamin and sodium thiosulfate. That's not what's going on here with opiate overdose. Opiate overdose is a hypoxic arrest. You have to fix the hypoxia, and then hopefully you get the patient back. Now, if you give them the Narcan, the only thing you're going to achieve is sending them into withdrawals, potentially, and making the heart muscle more irritable. So both of those things are actually more as likely to make the patient re-arrest as they are to assist the patient back to having a pulse. So for those reasons, those two reasons, it's not in the protocol and it's not indicated medically, you don't give Narcan during cardiac arrest. All right, let's look at number 10. Number 10 says patient's blood pressure of 72/48 with this rhythm. What therapy is most appropriate? Well, this is a basic, what I would call Edison or medicine question, right? Do you use electricity or do you use medication? And they do have a blood pressure, which means they have a pulse. So we're never going to perform unsynchronized cardioversion on anybody with a pulse. But with a blood pressure of 72/48, they are unstable by any definition. Their MAP is below 65. Their systolic is below 90. They're unstable. If they're unstable, they get the cable. The cable in this case is synchronized cardioversion at 100 joules, and that is the credited answer. Okay, number 11, you're administering an amiodarone drip for post-conversion prophylaxis in a patient that was converted from monomorphic v-tac into sinus tac. Okay, fair enough. By the way, that is something that we're supposed to do. If we have an unstable v-tac and we convert it with cardioversion, then we are supposed to give the amio drip to prophylax against recurrence of the rhythm. So, okay, upon reassessment, we now notice the below rhythm and the patient's blood pressure is 64/38. What's the first action to take? Okay, so upon reassessment, we notice this rhythm. This rhythm is a third-degree heart block. The QRS complexes are marching straight through. The P waves are marching straight through. This patient is a third-degree heart block, and they're unstable with a pulse of 64/38. Okay, fine. So the rule is that the first law of medicine is primum non nocere. First, do no harm. So what you have to realize here is as we're dripping amiodarone into this patient, it's a calcium channel blocker. And what you see here on the EKG is an example of a completely blocked AV node. right? So to the extent that the problem is a completely blocked AV node, the first thing you want to do is stop what you're doing that is blocking the AV node. In other words, with this rhythm, what it looks like is you have caused this blockade with the amiodarone drip. And so the first thing you should do is stop doing what you were doing that caused this problem, which means stop the amiodarone drip. First, do no harm. First, stop the amiodarone drip. Now, should you also do TCP? Yes, but doing TCP is, think of it this way. With the amio, it's like you have your foot on the brake, right? You don't push the accelerator until you take your foot off the brake. You don't want to have your foot on the brake and the accelerator at the same time. So first thing you do is stop blocking the heart, stop slowing the heart rate down, and then the second thing you do is try to speed it back up. So stop the amio drip is the credited answer. Okay, patients in SVT has a blood pressure of 96/44 and is acutely altered. Is the patient stable according to New York City REMAC guidelines? So the answer here is no. Their MAP is below 65 and they're acutely altered. They have a cardiac output related change in, or at least a potential cardiac output related change in mental status. They are not stable. And the point of question number 12 is to show you that you have to look at both the mental status and the blood pressure. You can't just look at the blood pressure, and if the blood pressure is over 90, just declare them stable. Right? If the systolic's over 90, just declare them stable. No. You have to look at both. You have to look at the mental status and the blood pressure. And if the blood pressure is borderline and the mental status is off, they're unstable. Okay. Patient is acutely unresponsive with a low rhythm and a blood pressure of 188/115. What is indicated? Okay, so this is a bradycardic rhythm. Looks like maybe a junctional rhythm, but it really doesn't matter. They're bradycardic, but their blood pressure is 115. So this patient is bradycardic and hypertensive. Those are two of the three legs of Cushing's triad. If the bradycardia was causing this patient to be hypotensive, if the bradycardia was causing this patient to have an altered mental status, they would be hypotensive. I know that the bradycardia is not causing the patient to have an altered mental status because they're not hypotensive. They are hypertensive. There's no way that a blood pressure of 188/115 isn't enough for this patient. So there's no reason to do atropine, epi, or TCP. Those are all interventions that increase the blood pressure. The blood pressure is already fine. All I need to do is a pre-arrival notification to the receiving facility. All right, patient's in monomorphic v-tac with a blood pressure of 60 by palp. Patient's cool, pale, diaphoretic. Patient is awake and groans to painful stimuli. They are not oriented to person, place, time, or event. Vascular access has not been established. Respirations are 24-minute. The SAT is 99 on room air. What's the most appropriate initial action? Okay, so your patient is unstable. They are in monomorphic v-tac. You need to cardiovert them. You don't have time to establish vascular access. You don't have time to get orders for sedation, and they don't need oxygen because their SAT is 99%. You need to immediately cardiovert them, period. Okay, question number 15. At least some amount of supplemental oxygen is always appropriate for patients with signs and symptoms of MI. True or false? It's false. It's false. AHA says that we should not give supplemental oxygen to anybody with an SpO2 of 90 or above and signs and symptoms of MI. And REMAC says appropriate oxygen therapy. So a reasonable definition for appropriate oxygen therapy is whatever AHA says is appropriate. So this is false. I know that there's this sort of heuristic of just everybody gets oxygen. It's wrong. It's just wrong. Oxygen is not benign. There's a lot of negative things that it does, and you have to be judicious with it. If you have a patient who's acutely short of breath, if you have a patient who is hypoxic, then yes, oxygen is warranted. But if you have a patient who, like the patient in number 14, has a SAT of 99, They don't need oxygen. Don't give it to them. You're hurting them with it. You're hurting them with it. Okay. That was the quiz. It was a difficult quiz. I am going to curve it a little bit. It was a difficult quiz. I think I'm going to give back probably 2 questions. I think I'm probably going to give back number 11 because I think it would be reasonable to say that you would immediately start TCP before you stop the amiotrip. You absolutely must do both, but I could see how people would say that it's reasonable because the patient's unstable. Your next step should be to start TCP. I get that, so I think I'll give you that question back. And I'll give you one other random one back, and what we'll do is I'll just grade it out of 13 as opposed to 15. And that should help you guys out. Remember, we will drop the lowest 2 protocol quiz grades. That said, we've sort of had an Algonquin roundtable of the senior staff here, and I want to share with you guys the perception of the senior staff is that these are all questions that are like very similar difficulty to what you see on the REMAC. So if you're struggling with these quizzes, you're going to struggle on the REMAC, and we don't want you to do that. So I want you guys to try to get yourselves to a place where you're doing really well on these quizzes, so that you'll do really well on the REMAC. Because you're going to have to deal with that eventually. So a schedule was sent out of what protocols you're responsible for when. For now, for sure, you're responsible for all your respiratory protocols and all your cardiac protocols, and we're building in more and more as time goes on. So you got to know these protocols cold, guys. And the other thing is obviously a lot of people are struggling with the pharmacology piece. If you're going to push a drug into somebody, you need to know everything about that drug. You need to know the duration of action. You need to know what it does. You need to know how it works. You need to know what it interacts with. It's almost a moral issue, right? If you're going to push something into another human being, you need to know what to expect. And it's, I would say, almost immoral to push something in another human being and not have an adequate understanding of what it actually does. So please study your drugs. Nikolai has sent out what I think is a very generous offer to give you 15 extra points on your A&P final if you do some work with the drugs. That, frankly, is work you should be doing anyway. So the fact that you can get 15 extra points is an enormous gift. So please, I strongly encourage you to take him up on that because it is a huge... It's something you should be doing anyway, and that's obviously a huge bonus. So I really strongly encourage you to do that. As always, I'm here for you guys. If you have questions, if something doesn't make sense, if something seems unfair, reach out and we'll talk about it. I'm a pretty reasonable guy, so if things aren't adding up in one way or another, reach out and we'll chat. Other than that, hang in there. You're almost at the halfway point, if not over it. So stick with it, and I'll see you around.